The very long title of my case is Retrospectively Diagnosed Familial Hypocalciuric Hypercalcemia Following Total Parathyroidectomy in an Asymptomatic Patient. So these are some of the contents of the presentation, but we will go through them in more detail. So starting with the introduction. So unfortunately, 15 minutes is not long enough to go over the homeostatic regulation of calcium metabolism, but it is something to keep in mind during this case. So as implied by the title, the case centers around familial hypocalciuric hypercalcemia, or FHH, and its differentiation from primary hyperparathyroidism. FHH is a rare autosomal dominant condition, with the most common type, FHH1, being caused by inactivating mutations in the calcium sensing receptor, or CASR gene. The CASR helps maintain a physiological level of ionized calcium in the blood. Calcium sensing receptor expressing homeostatic tissues include the parathyroid glands, the thyroidal C cells, the gastrointestinal tract, bone, and the kidneys. The loss of function mutation in the CASR gene increases the set point for calcium sensing. It makes the parathyroid glands less sensitive to calcium, and a higher than normal serum calcium level is required to reduce parathyroid hormone release. In the kidney, the defect leads to an increase in tubular calcium and magnesium reabsorption, resulting in hypercalcemia, hypocalciuria, and frequently high normal levels of serum magnesium. FHH is characterized by lifelong hypercalcemia, which confers minimal, if any, morbidity, and is mostly asymptomatic. There are some patients who may experience recurrent pancreatitis, in which case treatment may be necessary. Primary hyperparathyroidism, on the other hand, is a relatively common endocrine disorder characterized by excess production of parathyroid hormone, or PTH, by one or more of the 4 pea-sized parathyroid glands normally located peripherally along the margins of the posterior aspect of the thyroid gland. It is associated with significant renal and skeletal complications related to persistent hypercalcemia, which are sometimes referred to as bones, groans, and psychological moans, referring to the nephrolithiasis, abdominal pain, and depression often associated with the condition. While FHH shares features with primary hyperparathyroidism, such as hypercalcemia in the context of an elevated PTH concentration, it is distinguished by demonstrating relative hypocalciuria for the degree of hypercalcemia present. The effect of the loss of function mutation on the calcium sensing receptors in the kidneys results in an increased renal threshold for calcium, which causes lower renal calcium excretion compared to the enhanced filtered load of calcium. Family history, early age of onset, no previously demonstrated normal calcemia, and the lack of symptoms noted in FHH assists its differentiation from primary hyperparathyroidism. This distinction is significant as it impacts the appropriate management of the patient, given that primary hyperparathyroidism is treated surgically, while FHH often does not require treatment. So moving on to the case. The patient is a 21-year-old female who was otherwise well with no known comorbid illnesses. She was incidentally found to be hypercalcemic during baseline investigations performed for an elective procedure. She reported no polyuria, polydipsia, constipation, abdominal or bone pain, or any other symptoms of hypercalcemia. She had no previous history of renal calculi and no significant family history was noted. Her clinical examination was normal and with no remarkable findings. So biochemical investigations revealed a mild hypercalcemia of 2.84 millimoles per liter with an associated hypophosphatemia of 0.71 millimoles per liter. Parathyroid hormone concentrations were inappropriately, albeit mildly elevated at 10.3 picomoles per liter, leading clinicians to suspect a PTH-mediated hypercalcemia. Vitamin D toxicity was ruled out with 25 hydroxy vitamin D concentrations, which rather demonstrated a deficiency. Renal function was intact as indicated by the urea and creatinine concentrations. Based on these findings, the patient was referred from a peripheral hospital to the specialized surgery unit at our hospital for primary hyperparathyroidism and a parathyroidectomy. Taking note of the patient's young age, specialized surgery consulted endocrinology, who recommended that FHH be excluded prior to surgery. FHH was investigated for with the measurement of a urinary calcium creatinine clearance ratio, or what we commonly know as the fractional excretion of calcium, on 24-hour urine collections. This test was performed twice, and on both occasions, the clearance was borderline at 0.01. Literature supports that a fractional excretion of calcium less than 0.01 is indicative of FHH, and one greater than or equal to 0.02 is more suggestive of primary hyperparathyroidism. So this patient's results fell within that gray zone. Additionally, as part of the workup for primary hypoparathyroidism, parathyroid scintigraphy was performed to possibly identify the hyperactive parathyroid gland and direct surgery. This scan reported an ill-defined area of focal uptake above the left thyroid lobe. Skeletal survey and renal ultrasound confirmed the absence of skeletal abnormalities and renal calculi. So, unfortunately, the clinical chemistry laboratory was not consulted during the management of this patient. And based on the findings of investigations, the clinicians made a diagnosis of primary hyperparathyroidism, despite not definitively ruling out FHH. They decided to take the patient to theater for a partial or total parathyroidectomy, depending on intraoperative findings. Even though genetic testing for FHH is not currently available in South Africa, screening family members of the patient for asymptomatic hypercalcemia with a relative hypocalciuria may have aided diagnosis in this case prior to surgery. The clinicians were uncertain if the primary hyperparathyroidism was caused by a parathyroid adenoma or parathyroid hyperplasia, and so intraoperative PTH monitoring was available. However, intraoperatively, the 4 parathyroid glands were located, and all 4 were found to be mildly enlarged, and so the decision was taken to perform a total parathyroidectomy with reimplantation of a small section of the parathyroid tissue. Post-operatively, the patient did not develop hungry bone syndrome, which is sometimes seen following parathyroidectomy in primary hyperparathyroidism. She did, however, start to develop symptoms of hypocalcemia, such as tingling in her extremities and numbness around her mouth. And her serum calcium levels had dropped slightly post-operatively, and so she was given oral calcium and vitamin D supplementation, which resolved her symptoms. On discharge, her calcium had normalized, and her calcium and vitamin D supplementation was stopped within 1 month post-operatively due to hypercalcemia. So over the next few months post-operatively, the patient was noted to have a persistent hypercalcemia, despite cessation of supplementation and very low PTH concentrations, all of which is a strong indicator of FHH rather than primary hyperparathyroidism. By this stage, the patient's siblings and mother had been screened for FHH, and they were found to have asymptomatic hypercalcemia, and the 24-hour urine calcium clearance ratios confirmed the diagnosis of FHH in 3 of the patient's 5 siblings as well as her mother. A retrospective diagnosis of FHH was made in our patient. The patient and her siblings and mother with FHH are reviewed annually and have been hypercalcemic but asymptomatic to date. So let's discuss some talking points regarding this case. While differentiating primary hyperparathyroidism and FHH may have posed a diagnostic quandary in the past, improved understanding of the pathophysiology of FHH and awareness has led to decreased rates of misdiagnosis and unnecessary surgical procedures. Other than the early age of onset and asymptomatic nature, FHH is defined by increased tubular reabsorption of calcium, which can be investigated for with simple, easily accessible laboratory assays for urine and serum calcium and creatinine. While diagnostic cutoffs have been suggested, the gray area of a urine calcium clearance ratio between 0.01 and 0.02 may cause some uncertainty. However, the autosomal dominant nature of FHH can be exploited, and testing of the patient's parents and siblings could have occurred to confirm or exclude the diagnosis. While molecular testing was not available and may have perhaps been a limitation in this case, this costly and poorly accessible test is not always necessary to confirm a diagnosis of FHH, especially in countries like South Africa, where genetic testing is still limited. All this knowledge, which is well understood by the clinical chemistry department, could have been invaluable in the investigation and outcome of this case had we been consulted. So, as with most conditions, there are certain scenarios of FHH that do not follow textbook findings of a low fractional excretion of calcium, in which case other biochemical or molecular and radiological findings may also be useful. So this table has been adapted from the Teats textbook of laboratory medicine and lists clinical and biochemical findings that can be used to differentiate FHH from primary hypoparathyroidism. The features present in the patient have been circled in green. And as we can see, several characteristics of her presentation were in keeping with FHH, the others being borderline and a single feature in support of primary hypoparathyroidism. This case warranted exclusion of a diagnosis of FHH prior to surgery, especially when there was no indication to expedite surgery given that she was asymptomatic. So the strength of this case report is that it demonstrates a relatively classical presentation of a rare disorder, as well as how an inadequately investigated diagnostic dilemma and lack of consultation with pathology led to a needless surgery. The limitation of this case report is, of course, that chemical pathology was not actively involved in the decision making regarding the diagnosis and management of this patient. Regardless, relatively simple, easily accessible biochemical investigations were integral to the generation of a differential as well as the eventual diagnosis in this patient and several of her family members. Genetic counseling was provided, which will hopefully prevent inappropriate over-investigation and unnecessary procedures in other family members. Despite the clear value collaboration with chemistry could have had in this case, there was still no expression of any intent to improve consultation with the laboratory in diagnostically challenging cases by clinicians. This is a challenge we face often, working in a quaternary referral hospital that offers specialty and subspecialty care. And it would be interesting to see if it is a challenge experienced by others around the world. Improving on this multidisciplinary team approach and collaboration with clinicians is essential and something we keep working towards. So some of the important learning points and take-home messages from this case. Familial hypocalciuric hypercalcemia is a benign condition that can be distinguished from primary hyperparathyroidism clinically and biochemically. Educating and reassuring the patient and affected family members about the benign nature of this condition is very important. This communication avoids unnecessary and expensive monitoring as well as parathyroid exploration. Effective and collaborative communication between clinicians and the laboratory is crucial for proper and appropriate investigations, accurate diagnosis, and ultimately optimal patient management and outcomes. Thank you.